Katy Lees, Principal 340B Compliance Advisor with Virtue 340B. Welcome back. Or if this is your first time tuning in, thanks for joining me. As I mentioned, if you are here for my intro video, this is a new video series that we're trying at Virtue 340B. We plan to talk all things 340B. We'd like to make some new connections and just see where this takes us. So I'm really glad that you're here. Before we start tackling anything too complicated or getting in the weeds on all things 340B, I thought it'd be good if we started with some baseline information on the program. You know, whether you're completely new to the 340B program, have some experience under your belt, or are very well versed, I am really glad that you're here and I hope that you enjoy. I thought that we would start with a bit of a history lesson, super quick history lesson. We'll talk about the origin of the 340B program. The 340B drug pricing program was created by Congress in 1992. It was intended to address gaps that had been left by the Medicaid drug rebate program, which had been established 2 years earlier in 1990. While the Medicaid drug rebate program had reduced drug costs for Medicaid, it did not address the high drug costs that were being experienced by safety net providers like disproportionate share hospitals and clinics, which serve high numbers of low-income, uninsured, and underinsured patients. So these providers were facing financial struggles as they were not receiving the same discounts as Medicaid. The purpose of the 340B program was to make prescription drugs more affordable for safety net providers, helping them to reduce their drug costs and also allowing them to use those savings to expand other services. So that was a super quick, a little background on the program. The program is administered by the federal agency, Health and Human Services, more specifically, Health Resources and Service Administration, an agency within HHS, and actually, the subdivision of Office of Pharmacy Affairs is the office that directly oversees the 340B program. The program does not cost taxpayers any money or virtually no money because how it works is that drug manufacturers actually are required to give the discounts to safety net providers as part of their participation in the Medicaid and Medicare program. So in order for drug manufacturers to have their products, their drugs, reimbursed within Medicaid and Medicare, they also have to offer these 340B discounts to qualifying safety net providers. There has been a little bit of growth in the program since its inception in 1992. So around 2010-ish, the time that the Accountable Care Act was implemented, there were some additional covered entities or entity types added to the program. And then also at that time, contract pharmacy expanded. So like I said, since then, there has been some growth in the program, which has led to some controversy and scrutiny with some stakeholders questioning the scope of the program and transparency of the discounts, which at some point we'll probably get into some of that, but we're not going to talk about that today, but I just thought I'd mention it a little bit. But getting back to the basics of the program. So as I said, drug manufacturers are required to offer these 340B discounts to qualifying safety net providers. So how do these safety net providers qualify? You know, I'm not going to get too deep into the details on that, but, you know, hospitals and clinics that serve large number of low income or uninsured patients generally are the safety net providers that are able to qualify for the program. So there are many different entity types. So there are different types of hospitals that participate in the program, disproportionate share hospitals, so community, rural referral centers, critical access hospitals, and then there's also federally qualified health centers, Ryan White clinics, Title 10 planning clinics, and I have definitely missed some. That does not cover all of the covered entity types, but it is the majority of them. So as I said, there are different qualifications depending on the entity type, which at some point, if anyone would like to get into those details and like me to address it, certainly let me know, but I'm not going to get into too much of that today. Well, these qualifying safety net providers are able to purchase drugs at a 340B discount rate, but not for all drugs. They are only able to use 340B purchased drugs for anything administered or dispensed to outpatients. So it is an outpatient drug pricing program. So if you are in a hospital that participates in the 340B program, you're able to purchase these drugs at the discounted rate for use anywhere a patient has an outpatient status. So your emergency room, same-day surgery, hospital outpatient departments, did I say observation? Again, anywhere a patient has an outpatient status, a hospital or a qualifying entity is able to purchase drugs at a 340B rate to administer to the patient. Also, if there is an entity-owned pharmacy, so if a hospital or a health center has a pharmacy, the pharmacy can purchase drugs at the 340B discounted rate to dispense prescriptions to qualifying outpatients of the hospital. So it's very important to note that just because a hospital might own a pharmacy, every single prescription they dispense won't necessarily qualify for the 340B program. So if that hospital is purchasing drugs at 340B, they can dispense it to any patients that they are providing the care that's resulting in that prescription. So if someone comes and brings a prescription and has no other affiliation with the hospital, then that would not qualify for the 340B program. Also, there are relationships, which I mentioned earlier, had expanded in 2010, contract pharmacy relationships. So a qualifying covered entity, safety net provider, is able to have a relationship with an external pharmacy to also work together to provide prescriptions to patients of the entity. So how this works is that a safety net provider will say a disproportionate share hospital is participating in the 340B program, and they will contract with a pharmacy that's down the street so that essentially when that pharmacy is dispensing a prescription to the disproportionate share hospital's patient, they're doing that as an agent of the hospital. So, none of this is necessarily visible to the patient, but the pharmacy will dispense a prescription to the patient. Usually there's some behind the scenes software that's going to manage it. And if it's determined that that prescription originated from care at the covered entity, then again, it's essentially that the pharmacy is working as an agent to the hospital. The prescription goes to the patient, the pharmacy bills the insurance, collects the copay, and now behind the scenes, the revenue, the reimbursement from the insurance and the copay will go to the safety net provider, the covered entity, minus the dispensing fee that obviously the pharmacy has to, make something in the business transaction because they certainly have expenses and have, put work into that process. So they maintain a dispensing fee. And then the drug that they use to dispense it will be replenished by the hospital. So again, just really quick, we have hospital A and pharmacy B have a contract relationship. And when hospital A writes a prescription and that patient takes the prescription to pharmacy B, then that prescription is dispensed by the pharmacy, just looks the same to the patient, but that transaction is really like the pharmacy is dispensing the prescription for the hospital. Now, that obviously benefits the hospital because they were not part of this transaction before. and the pharmacy is now able to play a role in, assisting that safety net provider to generate some revenue from that prescription and also just extend their care to their patients. So as I said, that's called a contract pharmacy relationship, which is, if you're in the 340B space, is something normal and well known. But if you are not someone that lives or works in the 340B space, that might be semi-foreign and just not something that's been on your radar at all. I will say that controversy and scrutiny that I talked about earlier is very much associated with those contract pharmacy relationships. And as I said, we can get into that more as we move down the line in our video series. So now that we've covered the background of the program, just some of the basics, the participants, the players will say, let's talk a little bit about the rules, because that's, what it all comes down to is, yes, we participate in the program, but what are the rules that we need to follow to make sure that we're being a good steward in the program? First, as I've already spoken about a bit, drugs purchased at the 340B price are only able to be administered or dispensed to outpatients of the covered entity. So anything other than that would be considered diversion. It is completely on the safety net provider, the covered entity, to make sure that they are preventing 340B diversion. There must be systems in place to ensure that 340B drug is not going to an inpatient if you're in a hospital setting, or going to someone else that is not considered or not qualifying as a patient of the covered entity. So again, that's it. 340B diversion is the first rule and thing that we need to be worried about when participating in the 340B program. Number two, duplicate discounts. So covered entities must take steps to prevent duplicate discounts. And what this means is, we talked about the Medicaid drug rebate program, but we really didn't get into any details of that. So what that amounts to is that drug manufacturers are required to pay rebates to the Medicaid program. So when Medicaid reimburses a drug, reimburses a prescription, then they will submit a claim to the drug manufacturer to get a rebate for that drug. And if a covered entity is purchasing a drug at the 340B discount and billing that to Medicaid, then they have to make sure that they're notifying Medicaid that they use 340B drug so that Medicaid does not also request that rebate. That's what's referred to as that duplicate discount. Manufacturers are not obligated to pay a rebate to Medicaid and also give a discount to a safety net provider. And again, this is on the covered entity to make sure that duplicate discounts are prevented. There are different mechanisms, especially depending on what state you're in, that you would utilize to prevent duplicate discounts. So I live in New York State, where there's really clear guidance issued by New York State Medicaid that says how you must handle 340B drug claims if you're participating in the program and billing it to Medicaid. On the hospital side, if you're submitting a claim, you're required to put a UD modifier on the claim. That tells Medicaid that you use 340B drug and they will not claim the rebate. In the outpatient pharmacy setting, there's different billing rules and processes, so there's different identifiers that you would apply to the prescription, again, to let Medicaid know that you use 340B drug and that they are not to claim that rebate. Now, at the federal level, when you register for the 340B program, part of that process is you will notify HRSA if you will be using 340B drug for Medicaid patients or not. And how you answer that question results in how your entity is indicated on the HRSA database, also known as the 340B Office of Pharmacy Affairs Information System, or OPACE. So it will be indicated on OPACE if your entity carves in, which means that you will bill Medicaid for 340B drug, or if you carve out, meaning that you will not use 340B drug for patients that you'll be billing to Medicaid. So that information on the database is available publicly, so anyone can go see if you have opted to carve in or carve out. And your billing numbers will also be posted as part of that process in the Medicaid exclusion file, which is a report that's also available publicly. So while that is very helpful information, it's really what's at your state level is what is most important. I mean, that is very important. You definitely have to make sure your registration is appropriately indicated on your status for Medicaid. But preventing duplicate discounts is very important that you understand at your state level what those expectations are. There's a great tool. It's not 100% complete, but there is a great tool on the Apexis website that you can look up by state, and if it has been published by the state, or at least if it was at some point published by the state, then there will be a reference in this Medicaid tool on the Apexis website that gives you a summary of how Medicaid is handled in each state, and if there's claim level identifiers, if they refer to the Medicaid exclusion file. But I cannot express enough how important it is for you to understand how this works in your state. And if you live on a border, then you probably need to worry about how it works in multiple states. And on that topic, do not forget about out-of-state Medicaid. So let's say if you are in New York State, yes, you need to make sure that you're handling New York State Medicaid appropriately, but you also need to understand if you ever bill any other state Medicaids and how that needs to be handled. So we'll definitely spend more time on duplicate discounts in future videos. But just, that's a very important compliance element that I wanted to make sure we touched on here. A couple other rules that are specific to just certain covered entity types. So group purchasing or organization prohibition, or more commonly known as GPO prohibition, limits certain covered entities from using group purchasing organizations to obtain discounted drugs. So basically, if you are one of these entity types, a disproportionate share hospital, children's hospital, or freestanding cancer hospital, you need to be very careful when you're purchasing non-340B drugs for outpatients of your hospital. There are very limited, or maybe no, exceptions to being able to purchase other types of discounted drugs. Certainly not if you are getting that discount based on a group purchasing organization. Generally, if you're in the hospital setting, that's the type of discount that you would be able to use for the inpatient side of your hospital. So that GPO prohibition is very important for those covered entity types. The other rule that is just specific to a few different covered entity types, and mainly just the rural covered entities that were added to the 340B covered entity roster back at the inception of the Accountable Care Act. That's the orphan drug rule. So only certain types of hospitals need to worry about this. So community hospitals, critical access hospitals, rural referral centers, and freestanding cancer hospitals are not able to purchase drugs that have an orphan status at the 340B rate. So the orphan status is an FDA status that's given to a drug. Don't have that definition in front of me, and I don't want to screw it up, so I'm not going to go into great detail on this, but if a drug has an orphan status, then you are not able to purchase it at the 340B price if you're at one of those covered entities that I named. This one, while it is certainly a rule, it's probably the easiest one to follow, because generally if you are one of those entity types, you are not going to be allowed to buy an orphan drug at the 340B price. So while I won't say that it's impossible to violate this rule, I do think that this is one of the easier rules to follow, because by default, you are not going to be able to purchase these drugs at 340B pricing. So it's very important to have a strong compliance plan if you are participating in the 340B program. These rules are very important. They require, direct oversight. You want to make sure that you are routinely monitoring your program, that you have systems in place to make sure that you're able to prevent diversion and duplicate discounts. And then you want to be checking those systems all the time, testing to make sure that things are working as you're expected. So I cannot express this enough. This is what myself and many others spend so much time on, just making sure that program participation is being done compliantly. And I, would be remiss if I didn't say that this is definitely something that Virtue 340B can help you with. We have a few different options of offerings in this arena. We have a continuous monitoring program where on a quarterly basis, we will do a thorough review of your program data, or an annual audit as well, where basically we will do a mock audit similar to what would be administered by HRSA. So we definitely can help in that way if it's needed, but if not, it's something you can handle yourself, but do not underestimate the importance of a compliant program and being on top of all of those rules. I think I'm going to wrap it up here. I hope that you enjoyed this very quick walkthrough of the program basics. And like I said, if you think of any questions or any topics that you would like me to tackle in the future, feel free to reach out and we'll talk soon. Bye.